I'm just going to briefly go through the project objectives to sort of level set where we're at and talk briefly about the timeline. And then we have some sample topics that we hope can help you to shape the way that you give us your feedback. As Michelle said, please submit any written comments. We will read all of them to ratesettingeval@maine.gov. Can you move to the next slide? Thank you. So the purpose of the evaluation is to develop that system for establishing and maintaining rates that are sufficient to sustain the providers and ensure our Maine Care members have access to high quality services. It's also to evaluate Maine Care's rates and the rate setting system to develop a plan to create a comprehensive, streamlined, and coherent system for the future. So far in the progress of the project, this is an overview and a timeline. So we did release the initial cataloging and benchmarking report. This was after having provider listening sessions in October. We had some member listening sessions in November, and now we're at the second group of provider listening sessions here in December. In January and February, we have the interim and final report, and it contains all the information in the bullets that will actually be the findings and results of the report, plus all of the feedback that we get from stakeholders. Go ahead. So the meeting structure and rules for engagement. If you were with us at the last one, these will look very, very familiar. Our role is to ensure that the participants sort of keep their comments within the announced time limits. This is a smaller meeting, so I won't be putting hard limits because there are not that many attendees. So I'll just ask that you please respect each other and give each other an opportunity to get their comments out. Please also make sure that your comments pertain to the topic under discussion. Your role is to, prior to commenting, introduce yourself, your organization, and any services that you provide. This is so we can associate comments to the right section of policy. And if you hear something you agree with, it's perfectly fine to just say you agree with that instead of repeating everything the prior person said. And then again, just respect the time so that everyone has an opportunity to speak who wishes to. The purpose of today's meeting is really to gather those additional points for consideration regarding the rate comparisons, and then to let us know about the sufficiency of your current rates and any issues related to the rates and their impact on access or sustainability. We have a couple of sample discussion prompts. We're just looking at these as ways to guide the information that you give back to us today. So really, are there any assumptions or costs that are critical to consider that may be unique to Maine and wouldn't be reflected obviously in another state's rate? Are there any differences in methodology or services that could explain some of the difference in certain rates that wouldn't be evident through publicly available fee schedules or service descriptions? And then are there services where current rates contribute to access or quality issues? And then do those issues then impact other parts of the service system? So those are sort of like prompts to start the conversation. If you would like to speak, please go ahead and raise your hand or chat to us now, and Jillian will unmute you.
Okay, first up, I've got Diane.
Good morning, thank you. Diane Brassicott with National City Mobility. I just have a couple clarification questions I would like to get right off the bat from when I looked at the assessment. I noticed the various states for Medicaid comparison, not quite sure why 2 of the 5 states that were selected, as you probably can assume which ones I'm looking at. The second thing I have on there is looking at some of the analysis, I don't see NU comparisons where we know Medicare does pay for something even if they have an RR rate. This is really looking at your K codes and group 3 wheelchairs that I service, our company services, and looking at how they calculate and did the analysis on that. There were some concerns in looking at how the cures assumptions were done for the 244 codes that were applicable to those. Of course, this was supposed to be aggregate that is meant to be used against Medicare for those 244 codes. And I just want a little bit better clarification because even in the summary of the analysis, it doesn't quite line up. And so I would just like to have a couple of things up front answered in regards to those, and I will follow up accordingly through the rest of the presentation.
Okay, I will do my best to answer your question. So the 5 states were selected based on them being largely, well, geographically close, but also comparable. And one of the things that's important to understand is when we picked the strategy, it was for all of Maine Care's codes. So we weren't just analyzing DME. We were looking at all services for all codes across all of Maine Care. And so that means that some states are more comparable in some areas than others, but that's the reason why the states were selected. We also looked specifically for states that were not fully in managed care systems. So that was another criteria that we looked at. For some of the details of the DME specific codes and the RR rates, that I may have to get back to you on unless Jillian is able to answer that. The DME analysis was not my area where I have a lot of off the cuff, but I'm assuming you mean R&R was by report. Is that correct? By report costs? And not
Julia, I think it's actually rental, but just as a reminder to folks, so remember that the scope of this report was across all sections of Maine Care policy. So in part, I want to save Julia from having to answer, questions about every single code in Maine Care policy, because that's just hard to do, especially on the spot. So we will note your question, and if you could, like you said, email it to us so we can ask you any clarifying questions. Then we can get back to folks with a more precise answer. But I want to make sure that we don't get tied up in a Q&A because that could take over the whole session, and we'd really like to hear your other feedback. Thanks.
But with that in mind, do you have other comments that, other than the questions, that you would like to share?
I'll wait to see what this goes through, and then I'll send my email questions to the group.
Okay, thank you. Next up, I've got Kelly Hassett.
This is Mark and Kelly Hassett from Medcor Professionals in Scarborough, Maine. How's everybody doing today? I wanted to just first let you know that we had started our business 10 years ago in the midst of rate reimbursement from all areas, Medicare, private insurances. Maine Care was currently not one of them, but is starting to follow suit. In the arena that we had been able to procure the types of products that we wanted to issue, we had the fortunate ability to pick and choose those as we grew through a rate reimbursement. Now, other businesses in the state that had been established prior to us forming did not have that same luxury. So a lot of the rate reimbursements that are being picked away are really affecting those. As we see our particular products start to get picked away, we're starting to find that that we're not able to offer these in a reimbursable category anymore. So these patients, much in the realm of Medicare, mostly at this point, are paying out of pocket for the particulars that they come to hopefully get reimbursed. The one that I'm most particularly concerned about, and one of our largest programs here, really affects the non-narcotic space for pain management. And we're particularly concerned about this because it's one that we built our business on. It's one that has been an epidemic in the state as well as other states of rising opiate prescriptions and prescribing those. In 2012, 2013, Medicare had made drastic cuts to the TENS code specifically, and as well as others, making that an out-of-pocket expense for Medicare recipients. MaineCare has been kind enough to keep the code high enough where we've been able to provide a overwhelming support for MaineCare participants, and our program is growing. Over the past 10 years, we've seen not only the overdose deaths decline in the past few years. We hope that's attributable to a program that we've put in place and been able to really make well for the MaineCare members. So I just want to pay particular attention to the non-narcotic codes for TENS and cervical tractions and bracing in particular, and make sure that the EO 730 and applicable supply codes are on the high priority list that you guys have sent out. And I just want to make sure that we express our interest in keeping those alive for MaineCare members.
Okay, thank you. Next up, I have James McAvoy.
Hey, excuse me. Good morning. I'm Jim McAvoy. I am the CFO with Nordics Labs. We're based down in our core laboratory in Scarborough, Maine. Nordics is a Maine health organization. We provide about 4 million billable tests a year to the folks in Maine. We do that with 650 highly trained lab professionals who are located at 12 laboratories in mostly hospitals throughout Maine, and also at our core laboratory, a highly automated, very efficient laboratory located in Scarborough. And we also operate the laboratory over at Memorial Hospital in North Conway. Appreciate the data. It's actually well laid out. I found it relatively straightforward and pretty easy to understand, but I'm only referring to the laboratory section, which is in terms of coding and reimbursement, usually not that complicated. With regard to the actual 20 tests or 22 tests that were selected, the sum of the paid amount was $10.5 million. But within that data set of those 22, there are 6 tests that all pertain to toxicology screens and toxicology confirmation testing. And it really is an outsized dollar amount of that 10.5. The sum of the toxicology testing came out to just over $8 million in spend out of the 10.5 million total. I think that's a disproportionate representation of the laboratory business, and would ask that the state and the consultants, maybe expand the list from 20, maybe bump it up to 50 so that we could get a better cut of both the routine testing that are provided to patients, and then also include a few more anatomic pathology codes. And most importantly, and I think it's very important, that there be some analysis conducted about molecular diagnostic testing and genetic testing in the MaineCare reimbursement realm and coverage realm, for that matter, not just reimbursement, but looking at coverage of testing. I think most people know there's a tremendous growth in molecular diagnostic testing, much of it related to cancer diagnostics and carrier screening and care of pediatric patients with abnormalities. So that said, one other point, I think an important point for the folks to consider as they look at rate setting for the laboratory, is that the laboratory, for the most part, and particularly in the outpatient arena, is paid largely around the Medicare fee schedule. And in 2018, the first CMS PAMA cuts came into play. And since then, the Medicare fee schedule has been reduced 30%. So in the last 3 years, we've seen a 30% cut already in payment. It's concerning. It's a national rate. It does not reflect the cost of providing services in a rural state like Maine. And so we just, as we consider rates, we ask that some of this be considered and not blindly following Medicare as they cut rates as well. I think that's it for this moment. Can I answer any questions for you?
No, I think your comments were straightforward, and we've recorded your comments on some of the other testing that might be a good addition to the benchmarking.
Great, thank you very much.
Okay. I am not seeing any more. Oh, here we go. Shawn Andrews.
Yes. Can you guys hear me?
Yes, we can.
Okay. My name's Shawn Andrews. I work for Bedard Pharmacy and Medical Supplies in Auburn, Maine. We're under the Section 60 DME section. I do have a couple I know this isn't supposed to be a question and answer, but my first question, and I'll ask them and then maybe you can answer them after. The dollars that are being spent, that are being notated in this report, is that net of federal dollars or is that the main care portion? That's one question. And then when I'm looking at some of these codes that we're being impacted by, I think what main care needs to consider, or Myers and Stauffer, is that a lot of times main care is only the secondary payer in a lot of these examples. So when the rates are currently at 80% or below 80% of what Medicare is, we're not getting anything from main care as a secondary payer. So we're writing off that co-insurance from Medicare completely. And if you look at, I just looked at a handful of codes, but if you look at some of these codes, the dollars aren't significant on the amount of main care spend. So it's something I'd like the state and Myers Stauffer to consider. I can follow up with specific codes if that helps. And then I do have some other specific codes that I'm concerned about, mainly around codes that are newer to Medicare and where main care has implemented the 85% of Medicare, but that 85% of Medicare was from back in 2010 when rates were much higher. Newer codes from Medicare are much lower. So to start out at 85% of that amount, it just doesn't make sense on some of these codes. But those are some of the main points I just wanted to make. And if you could answer that question about the net of federal match, that'd be helpful.
Sure. For clarification, the amounts in the report are based on, yes, main care expenditure for calendar year 2019 service dates. Okay, and we will take your comment about, I don't know if you want to talk about some of those codes you were mentioning. In any sort of detail, if you wanted to email those, either way.
I could, yeah, I'll email them. I want to give other people opportunities to talk about their concerns. Oh, sorry, I did think of one other thing that because I'm reading the sample discussion prompts, and one of the things I think state needs to consider also is the fact that minimum wages have increased in this state, and they're continuing to increase. The cost of doing business has increased dramatically. I'm not familiar with all the other states that were listed in the report as far as what's going on with their minimum wages, but the cost of, to look at some of these states and just compare rates might not take into consideration the full cost of doing business, especially in Maine, especially with the rural nature of our state. I know the comparison states are somewhat rural as well, but we do have islands that we deliver to. not we don't necessarily, but I know there's providers that haven't been able to because of costs associated with that. Up in the county, I know that there's a lot of providers that need to deliver, oxygen tanks 2 hours away. So it's a 4-hour round trip drive. So things like that need to be considered. I know in the past, in dealing with Kristen at the state, we've talked about adding a delivery fee code that would benefit or help mitigate some of these costs, or at least account for some of these costs. So I hope that's in consideration as well.
Okay, thank you, Shawn.
Thanks.
Next up, I've got Laura Willard. Laura, you should be unmuted, but I'm not hearing anything. I'm showing you as unmuted, but I'm not hearing anything. Let's see. I don't know if there's anything I can do on your end. We're not hearing anything, so if you could, oh, I'm hearing something.
Yeah, can you hear me now?
Yes, I can.
Perfect. Sorry about that little technical issue here. So my name's Laura Willard. I work with the American Association for Home Care, and I'm also on the Homes Association Board, which is the medical equipment associations that represent from a national level and from a New England level as well. And I've had the pleasure of working with Myers-Stauffer and many other states regarding some of the analysis and all in other states. So I've got a couple of points here to make, and certainly we'll follow up with, I'm sure, lots of information beyond this. When you evaluate these states, I'm looking at the average rates for some of these items, and I've worked pretty extensively with all of these different states regarding their reimbursement methodology for durable medical equipment. I've worked directly with CMS on the Cures analysis rollout, worked with Andrew Badaracco and Jeremy Solankas from CMS, and actually helped them with their list of questions and FAQs from the very beginning of this. When I'm looking at some of the rates, it does not appear to be a comparison of what I know to be. So for example, Montana pays based on rural rates. And out of the 5 states that you have here, there is only one that is paying based on Medicare non-rural rates. The rest of those are paying on the higher rural rates that are out there. And in North Carolina, they are going to manage care July 1st of this next year. And I've personally worked with them on their reconciliation for CMS around this, and they have not changed rates at all. They've actually completed their analysis, and they are under the aggregate spend by working on a reconciliation process through CMS, and I assisted them with that. But the concern there is they pay a daily rate, whereas that's not the case in most of the other states, and their rates have not changed at all. So I'm struggling a little bit with the average of these other states, because from what I can tell, I'm looking at the E1390, for example. What I can tell is, based on what I know on the rates from these other states, the average is not calculating up for me from that perspective. And so I know there's a lot of behind the scenes information to look at regarding that. So that's one thing I would like to offer, to maybe sit down and discuss the DME rates specifically around this and what we know from the other states, and working on this. We've worked with 39 other states across the country to help them analyze the rates, give them information, and to make sure that, number one, you're in compliance with the Cures reconciliation, the Cures mandate, and number two, that we look at the impact on the budget for the state, because our goal has been to not have any increase on the overall spend from your budget perspective, but to keep you in compliance, keep your budget at what it needs to be, and also ensure access to care. And I want to also put on, beyond what Shawn Andrews had said, he discussed the increased cost of care. We are right now in a pandemic, and we work with all of the manufacturers or members of the American Association for Home Care as well. And they have had to give surcharges to the DME industry. We are on the front line right now during the pandemic. We're servicing patients in the home, and there's an increased need for ventilators, for oxygen, for all of those items and services. And there has been a major surcharges that have been put into this industry that I'm afraid if you go and you make these changes, that you're going to have extreme access to care issues. So there's some pretty specific items and issues we need to discuss from a DME perspective. We have a study that was completed by Dobson DeVonzo that shows that there was an increase in oxygen alone of 20% in just the equipment charges. We're not talking about the other things like PPE, increased PPE, and all that has had to happen during the pandemic. Operationally, things have changed drastically during this time frame. And so I think there's a lot of further discussion that we would like to offer on behalf of AA Home Care and Homes to work with you, and let's take a look at these similar to what we've done in other states, and they've been able to remain compliant, meet their budgets, and keep access to care around this.
Okay, thank you, Laura.
Thank you.
Next up, I've got Jason Morin.
Hi, good morning, everyone. Can you hear me?
Yes, we can.
Great. Jason Morin from the Homes Association. And I just wanted to make a quick comment regarding, the practice, industry-wide in healthcare about using Medicare rates as the benchmark for so many of our rate-setting endeavors. And realistically, even though I know we're looking at different state Medicaid rates and even some commercial payers, Medicare really is the driving factor for most of their schedules as well. So really that becomes the most important factor when we're looking at these benchmarking across other fee schedules. And I'm sure Myers and Stauffer is aware of the fatally flawed competitive bidding program and what's been going on for the last decade. But I really just want to draw attention to the fact that over the last decade, the competitive bidding program has created a false bottom in terms of what these rates are. And I think that was clearly demonstrated by this last round of competitive bidding that CMS elected not to implement for the stated reason of not achieving the savings that they were expecting. The competitive bidding program had a huge number of flaws that led to the decreased rates. And then the industry worked very hard for a lot of years to try and get those problems addressed. And we made a lot of headway, and such that this round of competitive bidding was supposed to be the market correction because of the changes that were made to correct some of those fundamental flaws. So we're all very excited that CMS implemented those changes and that we were expecting to see a positive result this time. And from all indications, there was, in terms of the market setting rates that were more sustainable and would have gone up. So I think it's very important when you're looking at these that you look beyond just what rates are being used by Medicare and the other programs that are adopting percentages of or based off of Medicare fee schedules, and really extend that look into what the market is and what goes into the services that we're providing. That's all.
Thank you, Jason. Next up, I've got Jim McAvoy.
Hi there again. I forgot to mention one thing earlier. It revolves around the draw charge on our lab fee schedule, the CPT code 36415. And when I looked at the units paid, I noted that Nordex is probably 80–90% of that total unit number, which kind of leads me to believe maybe there might be an issue with the volume for the calendar year 19. So I'd ask somebody could look into that. That'd be helpful. Thank you. And thank you.
Okay, thank you. Let's see, I'm not seeing any new hands. If you had your hand up and your question has been answered, if you could lower it just so I can keep track if someone else has another comment that they would like to state, if they want to speak again. Okay, Julia, I'm not seeing any new hands or comments.
Okay, great. I do want to just open it up one additional time if people would like to make. Oh, I see someone just popped up. So I'll go ahead and halt and let I believe Cathy Hamilton had a comment.
Hi. Can you hear me?
Yes.
Okay. Hi, I'm Cathy Hamilton. I work for Celeron Medical Products. We do business in Maine, particularly in the mom and baby arena and nebulizer arena. However, I also am associated with the Homes Association and have worked with other DME in Maine in the past. So I've been in this industry since 2007 and have seen a lot of the changes that have gone on. I want to echo some of the concerns that have been raised here and kind of put a little bit of this together and maybe expand upon some of this. Competitive bidding, as Jason Morin and Laura Williams stated, has been a problem for this industry in particular because rates have been kind of applied across the board, mirroring Medicare rates in a state where there's no bid. Things have gotten handed down, and so it's been lowering reimbursement comparisons on the Medicare side, and that has created that challenging space here to base their rates off Medicare, because it's a system that we have no say in. We can't submit our cost of providing a product. And we've had this discussion many times with Kristen, Merrill, and all the other wonderful people that we work with regularly in that DME conversation at MaineCare. And they've been able to address throughout the state for different things. Looking at your data and some of these comparative rates and whatnot, I became immediately concerned seeing that Connecticut was included in the comparison because that's a competitive bid state. New Hampshire has a little bit of competitive bid in there in the southern part of the state. Those rates can impact the comparative rates, Medicaid sides, as a lot of the, as had been explained earlier, a lot of the rates that the Medicaids have are based on Medicare rates. So those are artificial. New Hampshire, I heard you mention earlier that you had tried to not have too much managed care, but there's a great deal of managed Medicaid in New Hampshire as a rate comparison. Other issue. Shawn Andrews did a great job about talking about the distance. But what also needs to be noted in this state is that we've had a loss of local providers. We were a lot of local providers with the nationals in there and among, and that's fine. But we're losing local providers, locally owned providers, more so than we want to as an industry, and we're losing them because the costs are too prohibitive. They don't have the scalability. I was very excited a little over a year ago to see that there was a new provider open up in Lincoln. A little small guy, I talked to him on the phone. He was a respiratory therapist, and he saw the need and he opened a location at a time where new locations just haven't been opening. He had to sell. He had to close his business and sell the patient load to a national because he couldn't make ends meet because of distance, the extra costs associated with that. Shawn mentioned minimum wage increases. Our wage base is a little higher than some of these other states that haven't increased minimum wages. So the cost comparison there is not reflective when you're looking at rates, because they can achieve if their minimum wage is lower than ours. also using the 2019 comparison info is a little problematic in my mind, just because we have the pandemic now. With the pandemic, as has been mentioned, the costs have been increasing dramatically. The costs of all products everywhere are going up. It doesn't matter whether it's a breast pump or oxygen concentrators. There have been intermittent shortages. There's been accessibility issues of products at the early part of the pandemic. The PHE costs were outrageous to get what was necessary to provide deliveries of service, to the point that for the Homes Association, we had been banding together to try and find personal protective equipment. To find that personal protective equipment, we were banding together to try, and we researched whether we could bulk order this and share it with our members, because nobody could get it unless you ordered in bulk. The prices have been extraordinary. And we see this in the states that have had to look at the gloves. And we've had here, the costs of gloves right now have gone up extensively. That's just an example of what's been happening in this industry with pricing for us to acquire the products that we're trying to provide to the beneficiaries out there that need them. Everybody, I don't know of any manufacturer that stayed the exact same dollars in pricing for product. That's not what I'm hearing out there. That's not what I'm seeing. And we've been fortunate that we can bring these issues to MaineCare and get some adjustments to be made. But to take and look at this type of a benchmarking report and take and use that data as being fairly compared to what's out there just doesn't reflect what needs to happen, in my opinion, to savings in the healthcare arena. We know that we're just a tiny, tiny little bit of the healthcare spend as a percentage, but we can't control our costs the same way as many other providers are able to. So if we want to keep competition, have local providers, and local benefit, and not that the nationals don't provide benefit too, they do. I'm not trying to be disrespectful, but able to still have some of what makes Maine and the DME industry special. And I say that with all due respect, because I know in my former role, we would look at how long people were staying at different patients' homes, because the patient hasn't seen anybody, and what should be a drop-off of oxygen ends up being a 15, 20-minute visit because the patient's lonely. These are the ancillary things that happen in this industry, and I'm not saying it's up to you to pay for that. I'm saying that it needs to be recognized that we're a little tiny piece of the healthcare space, but yet we are providing such a bigger service. And that service component has not ever truly been recognized in this industry, because, at our company, we have lactation consultants that are available to our 24/7. We have, we provide all these things. There's no additional reimbursement for that, as is with all the other industries, with the oxygen providers out there, 24/7 support. This is there and it's provided at no additional charge. Whereas if you're a doctor and medical care provider like that, and you need to ask your doctor a question, you can get an on-call question, but if they say, oh, we need to come in and look at that for a second, you're getting a bill. So I think that component really needs to be factored in there, and not just look at product codes, 20% or 40%, whatever that is. It needs to truly be reflective of what this industry is as a whole. It's much bigger than many people realize. Thank you.
Thank you, Cathy. Let's see. I'm not seeing any new hands or anything in the chat. I've got Jason again. Jason, you should be unmuted. If you are speaking, Jason, I don't think we can hear you.
I am speaking. Can you hear me now?
Yes, we can.
Okay. I just wanted to quickly follow up on something Cathy had mentioned. In recent weeks, I've had conversations with most of the manufacturers in our space, in the durable medical equipment space. And not only are they expecting continued difficulty in accessing some of the products in terms of manufacturing, with everything that's going on in the country with the vaccine rollout and the distribution, they're expecting major blockages to the supply chain, and they're issuing warnings kind of across the board to providers right now that they need to stock up on equipment because they're expecting the delivery infrastructure to be taxed to the maximum once the distribution model comes out, because a lot of the people in our space are assisting in that vaccine distribution. So I just want to throw that out there to capitalize on Cathy's point about the shortages, and we expect that to go well into 2020. I'm sorry, 2021.
Thank you, Jason. Next up, I've got Laura. Oh, there we go.
Yes, hi. Wanted to follow up as well on the Medicare rates. One thing that I believe we have not mentioned for the DME industry is that during this pandemic, beyond just suspending the competitive bidding program, there were rates that were put out there that were effective back in May of this year to account for the increased cost and all. It certainly doesn't cover it all, but there were CARES Act rates that are out there for the duration of the public health emergency. And then there was a recent ruling or CMS rule that was published that makes the increased rates for the rural areas permanent from this point going forward. So I think the rate analysis that you're using doesn't take into account the changes that CMS and Medicare has made due to the changes for the DME industry as well. So that fee schedule from our software can be found at CMS. It's called the CARES rate fee schedule. And again, it went into effect on May 6th, and it's still in effect today. And there's lots of discussion and conversation at CMS that we're having with CMS and with legislators to keep those rates at a permanent perspective as well. So again, something that's changed pretty drastically during the pandemic for our industry. So I think we need to add in that rate for a evaluation as well when you're comparing those, comparing the rates to what main care is and should be paying.
Okay, thank you, Laura.
Thanks.
Okay. I'm not seeing any new hands or comments in the chat.
Great. So there was one question, and Peter, if you could help me out with to deadline for written comments.
As things stand right now, the deadline for written comments is December 9th. We have gotten some requests to extend that, so we are considering extending it, but a decision has not been made yet. But be on the lookout for a listserv that could possibly extend it by a couple of days.
Okay, great. Thank you so much. So because we're only at 7:50, or I know 7:55 where I'm at, it's 8:55 in May. If there are any final comments anyone would like to make, I'll open it back up again for that. Not seeing any. Well, thank you all very much for, oh, no, Shawn Andrews just popped up.
Yes, thanks. I had messaged Peter directly. I should have messaged probably Jillian. My question, because Cathy alluded to it, DME section makes up a small percentage. It'd be helpful to know what that percentage is. I know that we have data on the Medicare side of things that were less than 1.5%. But I'd be curious to know what that is for main care. And then just to clarify, I couldn't really hear Peter. Did he say December 8th was the deadline?
December 9th, Shawn.
Oh, sorry, December 9th. I apologize. I couldn't hear. And will comments be responded to, or will they just be taken into consideration? And will we know what the responses were? How will we know what the responses were to those written comments?
As things stand right now, so I think Michelle mentioned at the top of the call, there's going to be an interim report that Myers and Stoffer will be issuing January 15th, and then a final report on February 28th. All of the comments that we're receiving are going to play into that January 15th report. I mean, because remember, we're doing this across all sections of main care policy. It will not be possible for us to sort of issue in that January 15th report sort of a comment by comment response the way we do in our rulemaking process. A lot of you are probably familiar with that. The Administrative Procedures Act, when we issue a rule, we get comments, and we are required by statute to respond to all of those comments in writing. We write up the summary, and then we give our response. We are looking at doing something similar to that for the February 28th report, because we will have more time to construct such a document by then, whereas by January 15th, that it would just be too much work to get that level of detail done. In the event that we do have follow-up questions, and you all have given us some very substantive comments, we're going to be looking over all of these, and it is fully possible that we would get back to you with our own follow-up questions on your comments to the extent that we need additional clarification. It's just that this particular session wasn't the time or place for us to sort of engage in that kind of dialogue with you. Does that answer the question, Shawn?
Yes, I appreciate it. And I'd like to add, I appreciate the transparency and what Myers and Stoffer is bringing, the fact that main care is offering that to all providers, and just say it's been a pleasure working with Kristen and her team when we've been dealing with other issues. I know Cathy alluded to that as well, but it's been very helpful to have a good dialogue from DME provider and homes, because I'm a part of homes as well. Having that communication with the department is very beneficial. So thank you for that. And thanks for the explanation.
Absolutely.
One thing I will mention also is that there is an executive summary posted up on the website that has all the workbooks that does put that does look more broadly across all the codes and does put sections in a little bit of context. So if you haven't had an opportunity to look at that, that might be something that is also helpful to look over. Okay, not seeing any other questions or comments. I just want to thank everyone again for attending today and for providing feedback. We really appreciate it. And we are very grateful that you spent some of your morning with us. Hope you have a good rest of your day. Thank you.